السلام عليكم ورحمة الله وبركاته. Hello everyone. I'm Ibrahim Al-Asiri and inshallah I will be with you to present this lecture which is very rich of many knowledge regarding environmental cleaning in our healthcare facilities and especially in dental setting. As introduction to this lecture, there is increasing evidence that healthcare environment is an important source of healthcare associated infections. Every facility must thoroughly clean its environment to prevent it from developing into reservoir for pathogens. Um, Many studies show that many microorganisms survive on surfaces for long period of time, like Staphylococcus aureus, which can survive more than 12 months, Enterococcus lives more than 46 months, Clostridium difficile, which can persist as more than 5 months. Environmental services in dental clinic. What we mean by this kind of services? These services, meaning non-critical services or equipment that don't contact the patient directly. It can be or it can become contaminated during patient care by droplet or direct or by indirect way. There are certain surfaces, especially ones touched frequently during patient care, like light handle, unit switches, and draw knobs, can serve as reservoir of microbial contamination. In general, environmental services can be divided into clinical contact surfaces and housekeeping surfaces like floor, wall, and sink. In some references, there is another named or terms for these types of surfaces like high touch surfaces, which those with frequent hand contact, low touch surfaces, those with minimal hand contact. As we said, like ceiling or floors. The high touch surfaces may be potentially reservoir for microorganisms. To prevent ourselves and our patients and our colleague from infection, we need to know how this microorganism can transmit it from one to other. There are many ways or many routes that can these microbes transmit. First one is droplet, and this in this way in this route, droplet of patients oral fluids are spread during aerosol generating procedure, as use of high and low speed handpiece, the air water syringe, and ultrasonic scaler, whereas the smaller aerosol particles remain airborne for a time. The larger droplet particles either directly hit an object like the clinician mask or eyewear or clothing, or settle on any nearby surfaces, usually within a few feet. The second route are directly, and in this route, direct spread of patients or a fluid to environmental surfaces occur when contaminated hands touches a surfaces, for example, when adjusting the dental light, flipping switches, touching a drawer handle, handling the curing light, or dispensing gun, or grabbing the air water syringe. The third route are indirectly or is indirectly, and in this route occur when objects contaminated with patient's oral fluid contact surfaces, such as when patient denture is placed on the countertop or when an instrument is laid down. After we know how these microbial agents can transmit it from one to other, we need to know how can we prevent or protect ourselves, our colleague or our patient in dental clinic. In simple way, by breaking the chain of infection. As you see in this figure, proper environmental cleaning is an important part of breaking the chain of infection and preventing cross contamination. There are common terms that we know about environmental cleaning. First term is cleaning. What does it mean, cleaning? It means the physical removal of foreign materials like dust, soil, and organic material like blood, secretions, excretions, microorganisms. Disinfections, and this is the other term, the disinfection, and it describes a process that eliminates many or all pathogenic microorganisms except bacterial spores. So, cleaning is the first step prior any disinfection or sterilization. What are characteristics of disinfectants? The disinfectants are categorized based on their microbial spectrum of activity as follows. High level disinfectant, which are disinfectant used for killing all microorganisms on submerged inanimate heat sensitive objects, and this kind of disinfectant used mainly for heat sensitive reusable items. The second one is intermediate level disinfectants, which are using for killing vegetative bacteria, most fungi, most viruses, and Mycobacterium tuberculosis var bovis. It's used for clinical contact surfaces, which are surfaces non-critical with visible blood. The last category is low-level disinfectant used for killing most vegetative bacteria, some fungi, and some viruses. It's used mainly with housekeeping surfaces like floors, walls, and with non-critical surfaces without visible blood or clinical contact surfaces. Selection of disinfectant. What are criteria for selection of disinfectant? This disinfectant must has fast acting, and this means fast acting on surface that we disinfect. It should be non-toxic either for healthcare worker who disinfect or the other who use the area or the clinic. It should be have surface compatibility and odorless, and these disinfectants should be soluble in water, environmentally friendly, and finally it should be economic. This slide show microbial disinfectant hierarchy intrinsic resistances from up to down. These are microbial which are most resistant to disinfectant in general. Start from bacterial spores, macro or mycobacterial uh, like mycobacterial tuberculosis, small non-enveloped viruses, fungi, vegetative bacteria, and finally enveloped viruses. For disinfectant from high level, it has an effective against bacterial spores, while other disinfectant intermediate or mid-level disinfectant or disinfection has an effective against mycobacterial, small nano-envelope viruses, fungi, vegetative bacteria, and envelope viruses. And in the other hand, low-level disinfectant have only or has only an effective against vegetative bacteria and enveloped viruses. We need to know that that high-level disinfectant are not used to clean any environmental surfaces in dental setting. So we don't need to have high-level disinfectant in our dental clinic. How to read a disinfectant label? With every disinfectant, there is a material safety data sheet or MSDS, which are document provided by the supplier or manufacturer of a chemical product that contains information on the product's potential hazards, health, fire, reactivity, and environmental, and how to work on safely with it. It also contains information on the use, storage, handling, and emergency procedure for this disinfectant. It's also have uh, many information about disinfectant, active ingredients, and regeneration number, direction for use, and which is very important to the one who use this kind of disinfectant in the dental clinic. Contact time, very important to know for the used disinfectant and other information that uh, the manufacturer mentioned or provide in MSDS. We have many products in the market. So, which product can we use? These products must be approved by MOJ, must be compatible with the service and equipment in our dental clinic, must be used according to the manufacturer's recommendations like dilution, temperature, water hardness, contact time. Uh, these are or this disinfectant must be used according to the product's safety data sheet, and finally must be dedicated only for healthcare facility use. Responsibilities for cleaning and disinfection. A very common question that we face during our daily work is who is responsible for cleaning and disinfection of surfaces in dental clinic. As we mentioned before, we have clinical contact services and housekeeping services. For clinical contact services, dental assistants are responsible for decontamination of reusable clinical equipment, disposal of single-use equipment, and cleaning and disinfectant or disinfection of high-touch surfaces. Housekeeping services, housekeeper or housekeeping staff is responsible for decontamination of the environment, mainly low touch surfaces. These two types of surfaces require different types of cleaning and disinfecting agents and protocol. What are clinical contact surfaces? These surfaces can be directly contaminated by patient materials, either by direct spray or spatter generated during dental procedure, or by contact with a dental worker's gloved hands. These surfaces need to be adequately treated before they become involved in the care of the next patients. These surfaces can be dental chair, high or light handles, switches, dental radiograph equipment, dental chair side computers, reusable containers of dental materials, drawer handles, sinks, and faucet handle used for processing contaminated items, countertops, bins, telephones, and doorknobs. We can minimize the spread of microorganisms from these surfaces through using impervious barriers to cover the surface during treatment, or by cleaning and disinfection or disinfecting such surfaces after patient treatment. Barrier protection like plastic wrap, bags, sheets, and tubing of surfaces and equipment can prevent contamination of all clinical contact surfaces, but it's particularly effective for those that are difficult to clean. And it's very important to change all barriers between patients. If barriers are not used for or because of any reason, surfaces should be cleaned and disinfected between patients with an EPA registered hospital disinfectant with a tuberculosidal claim like intermediate level disinfectant, a hospital disinfectant with an HIV or hepatitis B viruses claim, like a low level disinfectant, can be used if the surface is not visibly contaminated with blood. So, covering surfaces with an abrasive barrier is the preferred method of preventing cross contamination from clinical contact surfaces. Even if barriers are used, general cleaning and disinfection of clinical contact surfaces, dental unit surfaces, and countertops are required at the end of the work sessions. When barriers are used to prevent cross contaminations, they must be removed between patients, and a new set of barriers should be placed with each patient. After the removal of the barrier, the surface should be examined. If the surface is found to have been inadvertently soiled, it should be cleaned and disinfected before the placement of clean barriers for the next patients. Surface barriers should be impervious to fluid, as we said previously, to keep microorganisms in saliva, blood, or other liquids from soaking through to contact with the surfaces. So, barriers should never be used for more than one patient. It must be discarded after each patient and put a new set of barriers for the next patients. What are surfaces that we must cover by using barriers? Covering the air water syringe handle with plastic wrap to prevent contamination is also recommended. If units are set up at or the night before, a large bag can give overnight dust protection to the bracket table and handpiece unit. Light handles and light switches are commonly touched during patient care and can be covered with plastic wrap or bags depending on their shape. In addition, some lights have a removable handle or handles that can be cleaned and heat sterilized before reuse. If the water at sinks is not controlled by elbow lever, foot pedals, or automatic devices, dental professionals can cover faucet handles with plastic bags. What are steps for using surface barriers? Place each surface barriers so It protects the entire surface and will not come off when the surface is touched. Wear gloves when removing surface barrier after completing patient care. Carefully remove each barrier without touching the underlying surfaces, just to prevent any cross-contamination or protect cross-contamination. If a surface is touched during the barrier removal, pre-clean and disinfect the surface, then remove gloves and perform hand hygiene before applying the surface barriers. Discard used barriers into a regular trash. Remove and discard contaminated gloves. Perform hand hygiene and apply fresh surface barriers for the care of the next patients. What about cleaning and disinfection? To facilitate the daily cleaning, treatment areas should be kept free of unnecessary equipment and supplies. Dental team members who perform environmental cleaning and disinfection should wear heavy duty utility gloves and other uh, PPE or personal protective equipments like masks, protective eyewear, and protective clothing to prevent exposure to the infectious agents and hazardous chemicals. Choose a cleaner or disinfectant compatible with the surface to be cleaned and disinfected. To know this kind of information, we need to contact the manufacturers of dental devices and equipment to obtain information regarding material compatibility with liquid chemical germicides. As we said before, the first step is cleaning. If surface is not clean first, the disinfection process may be ineffective because organic matter interferes with the action of some disinfectants. Cleaning and disinfection is done at the end of daily work activities and are required if surfaces have become contaminated after barrier removal. Cleaning is using detergents or surface active agents to remove organic matter like saliva or blood and visible soil. This is done by physical action of scrubbing with detergent and surfactant and rinsing with water to remove substantial microorganisms. Confirm that the pre-cleaning disinfecting products have been prepared correctly if diluted and are fresh if necessary and following the required contact time. And we need to read and follow the product label directions. There are two methods for cleaning and disinfection. First method is spray wipe spray, and in this method we spray the surface with cleaning disinfecting agent and vigorously wipe the paper towel. Holding paper towel behind appropriate surface during the procedure will reduce overspray. Alternatively, saturate paper towel or gauze pad with the cleaning or disinfecting agent and vigorously wipe the surface. If cleaning large areas, multiple surfaces, or large spills, use several towels or pads so as not to transfer contamination to other surfaces. Disinfect the pre-cleaned surface by respraying the disinfecting agent over entire surface using towel or to reduce overspray or apply with a saturated pad. Finally, let the surface remain moist for the longest contact time indicated on the product label, and you can see that vertical surfaces may dry more quickly. And the second method, which are or which is for wipe discard wipes, obtain a cleaner disinfectant towelette from its container, close the container lid, and vigorously wipe the surface. Discard the towelette, obtain fresh towelette, and wipe the surface again for disinfection. Finally, we need to discard the towelette and let the surface dry. If the surface is still wet when ready for patient care, wipe it to dry. If the surface directly touches the patient's skin or mouth, we need to rinse or wipe off residual disinfectant with water. What are factors affecting cleaning or disinfection process? Type of cleaning or disinfection products, contact time, concentration of disinfectant, techniques and methods of cleaning, equipment used in cleaning or disinfection processes, physical and chemical factors like temperature or water hardness and pH. What does it contact time mean? It's the time that disinfectant must be contact with surface or device to ensure that appropriate disinfection has occurred. What about housekeeping services? Housekeeping services are less likely to be contacted with contaminated gloves, but may become contaminated with aerosol, spatter, or spills. So these kind of surfaces like floor, wall, and sinks pose the lowest risk for disease transmission and may be cleaned using detergent and water or an EPA register low level disinfectant or detergent. Depending on the nature of the surface and the type and degree of contamination. An EPA register or detergent should be used in patient care areas if contamination with blood or other potential infectious is suspected or reasonably anticipated. This may be especially important when there is moderate to substantial community transmission of highly infectious disease like COVID, influenza, or measles, or during declared public health emergencies or incidents, and there is no evidence support that housekeeping services pose a risk for disease transmission in dental health care setting. A schedule of housekeeping services, cleaning, and methods will vary according to the area. Like in dental laboratory, bathrooms, and etc. Surface and type of contamination in these areas. Floors should be cleaned regularly, daily or when required, and spills should be cleaned promptly. Vertical surface should be cleaned and disinfected at least every 3 months. Greater attention should be given to housekeeping services that will be frequently touched by patients or dental health care practitioners, such as door handles. For the walls, window coverings, and other vertical surfaces in health areas, it should be cleaned and disinfected at least every 3 months, as we said before. However, prompt removal and surface disinfection should be done when patient material visibly contaminates housekeeping surfaces. Regarding tools or equipment that we uh, need to use during our housekeeping services process, like mops and clothes. They should be cleaned after use and allowed to dry before reuse. Or we can use single-use disposable mop heads and clothes during a cleaning process. PPE, these are used during cleaning and housekeeping procedure and should be appropriate to the task. PPE used to prevent occupational exposure to infectious agents and hazardous chemicals. It's mandatory to follow manufacturer instruction for disinfecting or detergent products, including recommended use dilution, material compatibility, storage, shelf life, and safe use and disposal. Solutions should be freshly diluted at the start of each workday. At the end of the day, any remaining solutions should be discarded immediately and the containers scrubbed clean and allowed to dry to minimize bacterial contamination. Part of cleaning strategy is to minimize contamination of cleaning solutions and cleaning tools like mop heads or cleaning clothes. Non-disposable cleaning tools of the various areas within the healthcare facility like clinics, theaters, laboratories, hallways, offices should be separated and not mixed with those of other areas. A golden rule in cleaning and disinfection process is to follow manufacturer's IFU for disinfection, or instruction for use for disinfecting or detergent products, including recommended use dilution, materials, compatibility, storage, shelf life, and safe use and disposal. There are many considerations for occupational safety that we must keep in our minds during cleaning and disinfection. Always perform hand hygiene immediately before wearing gloves and immediately after removal. Train cleaning staff on appropriate use and removal of required PPE for all environmental cleaning procedure and tasks. Appropriate immunization protects staff and clients, patients, residents. Environmental service workers and housekeeping staff should be included in facility policies of staff immunization. If any of the staff were exposed to blood or body fluid and other infectious hazard, he should follow a reporting system which applied in the facility. Which PPE for environmental cleaning that we need to use during any environmental cleaning? Uh, it mainly depends on type of cleaning task that we need to do in our facility. For example, routine cleaning, we don't need PPEs unless spills or contamination risk have. For terminal cleaning, standard precautions, reusable rubber gloves. For blood and body fluid spills and high contamination risk areas, we need gown, plastic apron, reusable rubber gloves, face shield or face mask, and goggles. And goggles, it's depend on our risk assessment if we have or if there is splash risk or large spill. For droplet precautions or routine and terminal cleaning, we need gown and or plastic apron, reusable rubber gloves, face shield or face mask, and goggles. For when we have Environmental cleaning with contact precautions. We need gown and or plastic apron or usable rubber gloves. For airborne precautions, we need respirator N95, fit tested reusable rubber gloves, and preparation of disinfectant products and solutions. This task, we need PPE according to specifications in SDS of the solution or disinfectants based on manufacturer instructions. If SD is not available, then chemical resistance gloves, gown or apron, and face shield or face mask and goggles. It's very important to know how to deal with items that will transport to dental laboratory. For example, dental impressions, appliances, and restorations that are contaminated with saliva and or blood. These should be cleaned and decontaminated or disinfected in the dental laboratory as soon as possible after removal from patient mouth. Gross removal of saliva or blood can be accomplished by gently rinsing under running water in an laboratory sink to avoid generating spatter. After cleaning, it can be sprayed with an intermediate level disinfectant with tuberculocidal claim for manufacturer's recommended contact time. Refer to the impression materials instruction for use to determine compatibility with the disinfectant used. After rinsing the items, it should be placed in leak-proof containers to be ready for transportation to dental lab. If these items not cleaned and disinfected in dental laboratory, the laboratory should have designated dirty area for cleaning and disinfection of contaminated items prior to pouring or performing other procedure. If items that have not been cleaned and decontaminated are sent to external laboratory outside the facility, they must be shipped in accordance with MOH for shipping of infectious materials. For shipping to an external laboratory, the items should be placed in a sealed container with the method of cleaning and decontamination method documented on the laboratory slip. Because even items that have been cleaned and disinfected may have internal contamination, laboratory personnel or dental healthcare practitioner performing chairside procedures should use appropriate level of PPE including protective eyewear, gloves, and respiratory protection when grinding or cutting or polishing used items made from dental acrylic. Items returned from the dental laboratory should include information describing how the items was cleaned and disinfected before shipping. If this information is not provided or not available, appliance should be cleaned, disinfected, and rinsed to remove germicide prior to delivery. Used acrylic appliance like full denture, partial denture, or the orthodontic retainers are porous and may have subsurface bacterial or fungal contamination that may not be inactivated by surface cleaning and disinfection. These subsurface decontamination may also not be effective if appliances are encrusted with extensive calculus deposits. For fogging and UV or ultraviolet disinfection in dental setting, the CDC recommends against the clinical fogging of patient treatment area using formaldehyde, phenols, or quaternary ammonium compounds, but states that this does not apply to newer technologies like ozone mist and vaporized hydrogen peroxide that have become available since the 2003 and 2008 recommendations were made. The CDC doesn't yet make a recommendation regarding these newer technologies. The CDC also makes no recommendation about the effectiveness of UV light radiation devices for infection prevention in dental setting. What about blood spills and how can we manage it? Blood spills on any surface should be contained and managed as quickly as possible to reduce the risk of contact by patient and other dental team members. Gloves and other PPE as appropriate should be worn when cleaning the spill, visible blood or any other potentially infectious materials should be removed with absorbent materials like disposable paper towel and should discarded in a leak-proof, appropriately labeled container. Non-porous surfaces should be thoroughly cleaned with detergent solution and disinfected with a disinfectant with a tuberculosidal claim. CDC recommends against using a combination one-step cleaner disinfectant for this purpose. In areas of direct patient care, carpeting and fabric upholstered furnishing should be avoided because it's difficult to clean and disinfect it. Biological spill biohazard equipment or kits should be available to clean up any spills safely and effectively. And in this way, all work locations where employees may come into contact with blood or other potentially infectious material must have blood spill kits available to safely and effectively clean up any spills. Infection control team must ensure that each unit have at least one biological spill kit to manage any accidental spill of blood or body fluids like vomits in order to avoid risk of contamination and infection transmission. So this spill kit must include the following: personal protective equipment such as gowns, gloves, eyewear, and mask. Supplies include forceps, plastic scoop and scrubber, absorbent granules or pads, hospital approved disinfectant, yellow plastic bag, and sharp container. However, if such products are unavailable, a 1 to 100 dilution of sodium hypochlorite, uh, for example, approximately a quarter of cup of 5.25% household chlorine bleach to 1 gallon of water is an inexpensive and effective disinfecting agent. After that, remove the solidified waste material using the scoop and scrubber and carefully dispose all contaminated materials into the infectious waste bag. Add 1 tablet of chlorine disinfectant, 2.5 gram for every 150 ml, which equal 5,000 ppm, which is effective against any risky blood spill. Use disposable wiping cloth to wipe up all the disinfectant and then discard into the yellow plastic bag. Place all items including PPE into yellow biohazard plastic bag. Close the yellow biohazard bag securely with a fastener to prevent leakage. And finally, do hand hygiene. A very useful poster which can explain the steps which we talk about them previously to clean and disinfect any area of blood spills. Here are some criteria for utility room, uh, which must well ventilated and illuminated, lighting or window access, must labeled with biohazard sign on the door and restricted, have an appropriate water supply, hot and cold water access if feasible, have a utility sink or floor drain for safe disposal of used solutions, must have dedicated hand washing sink used only for hand washing, have access to any eye wash stations, have appropriate PPE available. What about pest controls? Do we need to have it in our dental settings or dental facilities? The presence of cockroach, flies, maggots, ants, mosquitoes, mice, rats, bedbugs, and other pests is an indicator of any unhealthy environment in the healthcare facility. Environmental health staffs are responsible for coordinating pest control. Although environment health personnel play a major role in minimizing pests, facilities should consider contracting licensed professionals to handle toxic pesticides. For quality monitoring and auditing component, we have many methods which can help to know if we do a good cleaning and disinfection for environment. Each one has advantage and disadvantage based on the technique uh, or that applied in this method. First one is visual assessment, which can did by trained observer, for example, from anyone in infection control department, which or who can assess cleanliness of an area following cleaning. This method has advantage like easy to implement, allows feedback to environmental service staff, while disadvantage is a result don't correlate with levels of microbial contamination, doesn't assure that healthcare clean has been achieved. Results may vary across different observers. The second method is environmental cleaning performance observations, which done by the environmental service supervisor observes environmental service workers performing cleaning. Advantage for this method: easy to implement, useful to assess that facility procedure for cleaning are performed correctly, allows feedback to environmental service staff. While disadvantage is time consuming, labor intensive, performance while observed may not be the same as performance when not observed. The third method is environmental marking. In this method, prior to cleaning, environmental surfaces are marked with an invisible tracing agent that can only be seen using a refilling agent. After cleaning, a trained observer can check to determine if the tracing agent was removed from the surface during cleaning. Failure to remove the tracing agent from a surface suggests that the surface was not cleaned. Advantage for this method: it allows direct assessment of cleaning, allows also assessment of which high and low touch surface are cleaned consistently and are omitted, associated with rapid improvement when constructive feedback is provided. Easy to implement, result easily understood. While its disadvantage is or R doesn't directly measure microbial contamination, doesn't measure quality or intensity of cleaning, uh, doesn't assess adequacy of cleaning of unmarked surfaces. Surface texture may affect the removal of tracing agents. The last method for quality monitoring and auditing component are or is adenosine triphosphate. In this method, we use ATP is a substance found in all living cells. Surfaces can be tested after cleaning to determine the quantitative level of ATP present. Advantage for this method are allows assessment for residual organic material present after cleaning, provide a quantitative result, easy to implement, provides quick and direct feedback. Its disadvantages are not a direct measures of microbial contamination. Some cleaning products may interfere with the test and doesn't assess the adequacy of cleaning of unmarked surfaces. Conclusions for this lecture. The healthcare environment contains a diverse population of microorganisms and can be a reservoir for potential pathogens. Collaboration between infection prevention and control and environmental services staff limits the role of the healthcare environment in disease transmission. Thank you for your attention and goodbye.